honored to be here. I would like to thank the organizational committee for the invitation. And thank you for being, I'm able to speak about one of my favorite topics, which is smoking cessation in respiratory patients. This is what I do in my everyday clinical practice. I'm a pulmonologist. I work in a medical center in primary care. And I work there, but I thought I should do more for my patients, and then I took the advantage to go to a organized smoking cessation center, and I'm working also there for more than 1 year. And I have to say that this is the only way we can help people, we can help smokers, only if we can implement smoking cessation into our everyday clinical practice, and to be able to be available when the gold moment comes, when someone is motivated to stop, we should take advantage of it. So, again, I'm going to speak about nicotine addiction. According to WHO, it is a chronic disease, and we need to change our perspective about that. It needs continuous care, and treatment. And the good news is that we have evidence based that there is an efficient treatment. This is pharmacotherapy and behavioral support. And of course, we need to take care of the relapses. Tobacco use is a risk factor for 6 of 8 leading causes of death in the world. And among them, there are 5, which we call big 5s, which is lower respiratory infections, pneumonia, asthma, COPD, tuberculosis, lung cancer. They are being called like the big 5s, which are the biggest burden of mortality globally. And we should do something. We should do something because all of these big 5s are worsened and can be prevented by something, which is smoking cessation. So, of course, we need to speak we need to see in different levels. We need to see why it's difficult for the patient to stop. And we know about addictions, we know about dependence, and we know that it's difficult for them, and we need to we need to respect that. As a doctors or healthcare providers, we need also to change something. We need to own this disease approach that it is a chronic disease. We need to diagnose, we need to assess, we need to treat, we need to follow up, we need to repeat intervention, and of course we need more skills. We need more communicational skills, we need motivational interview, and we need to handle also the frustration that also the previous speaker said about when you have all this negative attitude toward a person that you suggest something and this is not accepted, or a person that does nothing to change it. So, and it takes time. It takes time also for the doctor to change, to own these skills. And of course, we need to do something, more systematically, like a tobacco control policy, which can influence both, and patients and healthcare providers. And we need to make it also accessible and affordable, because for many of them, it's not so easy accessible. They are cost, especially here in Greece. So, yes, we know smoking, we know tobacco use, and second-hand exposure are related to respiratory diseases. And here we see that the European Respiratory Society addressing this issue and making smoking cessation a high priority. And should be integral, should be included in the therapy, in everyday praxis. The product of this task force was a monograph in 2008, and here are the conclusions. Patients with respiratory disease have a greater and more urgent need to stop smoking than the average smoker. Smoking cessation treatment should be integrated into the management of the respiratory condition. Therapy should include pharmacological treatment combined with behavioral support. This is evidence-based. We need training, and we need also money. We need budget to establish this implementation. Of course, we will have many benefits of smoking cessation, but we need also to go for a budget that can permit to bring this change, also in behavior of our patients, but also in our praxis. In 2015, ERS continue in the same direction. Smoking cessation is crucial for respiratory patients, and every patient must be given advice and help to quit. The product of this work was a consensus document. 4 main diseases like COPD, lung cancer, asthma, tuberculosis are detailed, described. I mean, the epidemiological links with the smoking are described in this document. We have the benefits of stopping smoking described as well. Also, which interventions are best for which patient. And for the first time, we see that we need specific management for the hardcore smokers. Smokers with respiratory disease are complex and difficult to quit. So let's look at the characteristics that these smokers have. They are more addictive. They're more addicted and more dependent. They are patients with comorbidities and also cardiovascular diseases, diabetes, psychiatric diseases. Also, they have a higher percentage of depression and anxiety. It's important that these people, this patient, use smoking as a medication because this is the best way they know to treat, to deal with a psychological problem. Another thing is that they are coming from low, middle socioeconomic status, and usually they don't have the access to primary care or to healthcare generally. I will speak about COPD, the third leading cause of death. There is a strong relationship between smoking and COPD, and 40% of COPD patients are smokers or ex-smokers in the developed world. Here is the diagram of a natural history. Here is described how smoking affects the lung function. And you can see in the black line how the lung function naturally declines by the age. In the red line, you can see how this lung function declines when someone is smoking. And you can see that there is hope. It has been evidence proof that if we stop smoking earlier, we can slow down the acceleration, we can slow down the decline of the lung function. We have benefits. Except the lung function, we have, it improves responses to treatments, it reduces the incidence of acute exacerbations of COPD, it reduces bronchial infections. It is evidence-based that smoking cessation in COPD is the most effective measure for controlling the progression of COPD. You can see here, once again, how many are the comorbidities of a COPD patient. There are many. We speak for complex patients, and usually they come with a bag of medicines, treatments for their heart problem, for their psychological problem, and they usually say, you know, I don't have any pleasure. The only pleasure I have is smoking. Why? 40% of COPD patients remain smokers even after the diagnosis. Usually, we hear in the respiratory clinic, why should I quit? I'm already ill. The harm is done. I see that most of the characteristics that I described before for respiratory patients, for patients with respiratory problem, are also here in smokers with COPD. For them, it's harder to quit because they are more dependent to nicotine, because they usually have a higher number of cigarettes smoked daily, because they have depression and they use smoking as a self-medication. And also they are coming from low socioeconomic status. It is interesting that smokers with COPD inhale smoke differently. They inhale a greater volume of smoke and they inhale it more deeply. We have an algorithm here in our hands from this document, and I will go in it in detail. We know that it is important to assess, let's say diagnose, okay? So we need to know the number of the cigarettes per day, we need to know the number of the years smoking, and these usually give us what we usually write down in our patient files, like the pack years, and it's an important thing to know because it correlates strongly with the risk of developing COPD, a worse COPD stage, and a faster progression. We use as many tools as we can. Usually, we use the index of exhaled carbon monoxide, and previous speakers said about it. It is something which is portable. You can use it everywhere. I mean, we use it usually in the smoking cessation clinic, but you can easily present it to the patient, and the patient the smoker can easily do it without difficulty. And it's important that it motivates along smokers. It motivates. It's like our cholesterol, let's say. Spirometry. This is another very important tool that we have, and I've seen it. I've seen people coming for spirometry, and because we say to them, okay, please, before you come to spirometry, please don't smoke. And it's important to, we usually do the spirometry, and I ask them, how was it for you to stay free of smoke today? Or there is some spirometries that can estimate the lung aids, and this is also something which we use in our everyday clinic, and it really helps them to understand what they are doing. Motivation is self-efficacy. We don't have something like a measure, but we have some questions that we usually use, and we want to assess motivation. Well, let's say we will ask them, how important is it for you to give up smoking? And we ask them to reply to us from a scale from 0 to 10, in which number they place their willingness to quit. And also, we ask about self-efficacy. How confident are you that you will succeed if you would make an effort today? And again, if we have these two questions, if the person feels ready to quit and is confident enough, we usually set a quit date. And we do it immediately. We don't lose time. If the motivation is high but self-efficacy is low, usually we need to assist to offer the chance of treatment and support, which is very critical for success. Maybe we say to him, maybe it will be a good idea if you would like to join a smoking cessation center, or I will give you a referral. Let's see if what is going on if self-efficacy is high, is a person that has that can do whatever he wants, but the willingness is low. Effective health education and motivation interview is more critical in this situation. If both are low, then we need more intensive support. We see that smokers with COPD are motivated to quit, like every other smokers, but most of them, they're reporting less self-efficacy and less self-esteem. Usually, the reason they want to smoke is because of their health and the improvement of their symptoms. Again, as I said before, we estimate the tobacco dependence. We can use the questionnaire. We can use some simple questions like the time to first cigarette of the day, or we can simply ask if you smoke during the night. Here I present to you the test that we use. It's easy. We can have it everywhere. I mean, I have it in my office, and usually when I have a person who is smoking, I do the CAT score, and I usually do the Fagerström test also. It is important because it predicts difficulty of quitting. It predicts severity of withdrawal symptoms and need for pharmacological treatment. It is a good chance for us to see if our patient is dependent and to be proactive and say to the smoker, oh, maybe it will be very difficult for you. So, I would like to continue. It is important to know if the person that we have opposite to us have done previous attempts to quit. And we usually know that the person needs 4 to 7 attempts to finally quit. We need to know about the duration of their last effort, the reason that they relapsed, if they were dealing with a situation like withdrawal syndrome, and what was the treatment they received. And again, most importantly, the assessment of depression. Have you been feeling down the last month, or have you had little interest in doing things? It's 2 simple questions that can address depression. I will say that in more severe, serious COPD, the co-extent of the depression is reported in 45% in hospitalized patients. And we have to see that there is a circle between smoking leading to COPD and COPD leading to depression. And this depression is also by itself a negative impact on cessation of these smokers. We have evidence-based that counseling combined with pharmacotherapy is very helpful. We need to be clear, we need to use every tool we have, we need to help them organize a program and also arrange follow-up visits, provide self-help materials, but we need to be careful. We need to be careful because these patients, these smokers, usually are tolerant to medical advice, and they use denial. They increase their denial so they don't hear us. They are resistant to medical advice. And if we see such a person, we should be more open. We use more open-guided questions, like, what are your thoughts about smoking at this time? We use empathy. We use body language. We don't judge them. We don't judge them if they use electronic devices or if they use smokers. We're being empathic, and we say, I understand. And sometimes we congratulate them for every effort they do. We use, of course, we need to take care of our body language. We shouldn't be critical towards them. We need a more patient-centered approach. We need to investigate the specific motives that this person, this smoker that we have is having. And we need to link them with every opportunity, with every respiratory symptom, the cough, the breathlessness, the wheezing. We need to link it to smoking because maybe they don't know or maybe they deny it. We need to emphasize on the benefits from smoking cessation. We need to have a positive tone and provide information and tools. It has been shown that also group interventions are equally effective to individual support. We need to know that hospitalizations are important moments, are opportunities. Also, when we prescribe, let's say, long-term oxygen therapy is another teachable moment. As previous speakers said, we have their pharmaceutical therapy that have proved their effectiveness, the nicotine replacement therapy, bupropion, and varenicline has also proved their effectiveness. And usually this is the standard approach. I put it like that, so you can see that we can start the nicotine replacement therapy immediately after the quit date, but for varenicline and bupropion, we need to start earlier. Counseling is very important, and it is all during all the procedure. We have meta-analysis, especially for COPD patients, which provide us with evidence that these are the most effective intervention, counseling and NRTs, counseling and antidepressants, and we have also a more new meta-analysis, more meta-analysis that goes on with this, and varenicline is also added in our treatments, in our interventions. As in conclusion, we need adequate support, either individual or in groups, and we use it in combination with a first-line pharmacological smoking cessation agent. And we're not afraid of the relapses. Relapses occur. We need to retreat them, and we need to be supportive. I'm wondering about the new technologies, yet we don't have evidence about COPD patients or patients with respiratory problems, but maybe this is a good way because there are people that usually stay at home or, I don't know, I mean, I thought maybe this should be another field of research. And let's speak a few things for another situation, which is lung cancer. I don't have so much time, so I would just say that smokers with lung cancer have a lot of benefits in improving their quality of life, in reduction of surgical complications, increasing of survival time, and usually these patients are willing to quit. Also, they have high levels of nicotine dependence, but they're willing to try, and we need to be focused also and don't lose this opportunity. Still, if a person is diagnosed with lung cancer, there is a 10 to 13% of people that still smokes 6 months after following the diagnosis. And there are some factors associated with non-quitting, like younger age, depression, and having a household member who smokes. Also, some comments, if you permit me, about smoking and asthma. The prevalence of smoking among people with asthma is similar to the general population. Smoking has detrimental effects on asthma, and people suffering from asthma are also higher nicotine dependent, and they are not willing to go to educational program or to go to a smoking cessation program very easily. We don't have such many evidence, a lot of evidence about this group of patients. TB and tuberculosis and smoking tobacco, it is a deadly combination, and there is many effort is done towards this to provide the evidence that people who smoke have a greater risk of developing TB and have a greater risk of dying from TB disease. It is a global emergency, and this is the reason I put it here in my presentation. I will go and say something about reduction. Is it a possible gateway to quitting? Maybe. Although the reduction of risk associated with reduced smoking is not clear. Maybe because smokers usually compensate with vigorous puffing of the remaining cigarettes. So we have also some guidelines, some suggestions on how to treat, on how to guide people that want to reduce cigarettes. We give them counseling, and we use it as a tool to increase self-efficacy. We congratulate the patient, we congratulate the smoker if he managed to reduce the cigarettes, and we can also offer pharmacological treatment for that. A comment about failure to treatment. We can modify, we can extend the treatment, we can use a combination. This is also something we didn't know at the past. So I think we are doing progress in that also, in which way to treat the failure or the relapse. I had some conclusions for the accuracy of my presentation, but I will not go for them. I would just say that we need more training. We need to be ready for the gold moment, as I say. When the smoker comes, we need to be ready. We need to give them the advice. I would like to thank you very much and make every day World Number Tobacco Day. Thank you.